Dr. Mark Wichman from Aurora Advanced Healthcare, section of Orthopaedics and Sports Medicine. We're going to talk a little bit about defects of the knee, cartilage defects of the knee, and ways that we can reconstruct those defects or repair articular cartilage, which I refer to as surface cartilage of the knee. So here we have a model of the knee and an actual cadaver specimen of the knee. And what we're going to show is what that normal, pristine surface cartilage looks like on the inside of the knee. So this is a left knee right here. This is the end of the femur bone right here. And you can see that smooth, beautiful, glistening cartilage that we all wish that we had in our own knees. Shortly, I'm going to make a little defect that simulates a defect that a patient might have after injuring the knee in some type of sporting injury or other type of injury. And then I'll show you a couple different ways of repairing that. Here's a defect that we made on this is now the lateral femoral condyle. So here's a little defect that I made. Let's pretend he had a really good soccer game, scored a few goals, but this was the consequence. So we'll see how we can do to replace that. Now this is an area of the knee that we don't walk on. When we straighten the knee out right here, it leaves an area right here that we actually don't walk on. An area that's ideal for harvesting cartilage to transfer to the area that we actually bear weight, we actually load and walk on. So pain would then be alleviated if we can fill this area with healthy cartilage and some bone from an area up here. We're going to harvest the donor from a spot up here. We're down the right depth. We're going to try to get one fragment out of this. So we turn, and here we go. Here's the defect that we've created to fill the area on the weight-bearing surface. So I'll go ahead and create a recipient site that gets all the way around this site and then some in order to make sure that there are no areas that are not covered by this. So this is our donor. We're ready to fill the site that where the cartilage was bad, and we're going to try to approximate the same angle. We've marked it in all of our quadrants so that we know about our depth, so that we can make sure that we simulate, that we reproduce that surface cartilage as accurately as we possibly can. So you can see right here, we've now repaired that cartilage. It's nice and smooth, and it doesn't stick out, but it's not recessed either. That's just about how we want it. And now I will take what's left of the bone that we took out from this spot here, and we will fill that and backfill that into the defect that we created. So this is the standard Oates technique that you may have heard or read about, or we may have talked about in the office, in your particular case. So we've marked here the 20 millimeter recipient site where we've got all this wear and we've got all this big injury, and I marked the north so I know which of the quadrants that we are, so when I match our donor up to this, I know which side is up and which side is down. This is a fancy, extremely sophisticated device that's meant to hold our donor in place, perfectly in place, so that we can come down right on top of it and take out just the perfect specimen that will fit the defect that we're trying to fit. So now we've put the 20 millimeter reamer right on there. We can go ahead and take our donor. So you can see we've taken this core right out of the donor spot here, and we're about to prepare this so that it fits our recipient. We'll just tap this plug right out of here that we just harvested, and we'll fashion it to fit the defect that we have. So we place the pin directly in the center of the area that we're going to replace, and then there's a special device that we can use that will create the perfect recipient, and with all these calibrations on the side, so we can see exactly how deep we're going. So we'll clean that up for the recipient to go in. We'll measure all the quadrants so we know we're going to have a good fit, and we'll go from there. All right, for all you woodworkers out there and that have actual interest in the details here, we want to make sure that we measure the depths at all the 4 quadrants of our defect here so that we can tailor those to fit the graft, so the graft isn't proud in one area and recessed in another area where it might see different asymmetrical loads. So now what we're going to do is I've marked the graft so that all the way around we've got all the 4 quadrants measuring north right here, all the 4 quadrants exactly like I wanted to, so we can make a nice level cut. Of course, in orthopedics, you measure twice and cut once. That's what we like to do. It's pretty flat there. Sort of test to make sure it's nice and flat this way. So this is our plug. I've tapered it down so that it should fit nicely into the recipient site there. And then the one thing I would do here if I was in a real operation is I'd take a special water pick device and flush this graft as much as I possibly could of all the cellular debris, of all the marrow contents that reduces the risk for the body to recognize it as being a foreign material and mount an immune reaction to it. All right, now the moment of truth here for us to put in our defect real lightly, like that. And what you can see is this defect, this is really nicely filled in here. And I used the probe here to see there's a nice match right there. I chose a part of the graft that tapers into the corner right here because I knew that part of the condyle tapered in right there. So if it fits well, we don't have to use any screws or nuts or bolts or any other fixation devices. If it isn't fitting so well, we may have to augment it with something. So it looks great. Now this part will bear the weight. Of course, when the person straightens out the knee, that's the part that bears the weight, and that's a major weight-bearing part of the surface. And we've now reconstructed that with the cadaver graft. So that is called an osteochondral, osteobone, chondral, cartilage allograft, which is cadaver graft. So now we're going to the arthroscopic procedure. I'm going to show you one more thing. This is the microfracture. If anybody picks up the sports page of your local newspaper, it's going to talk about the latest NBA player who's had a microfracture of the knee. It's a long word. I know not a lot of people understand what it is. So I'm going to show you what a microfracture is. And if we can zoom over onto the screen here, we can see the inside of this person's knee. This is raw bone surface right here that I'm demonstrating right there. And that should be smooth and glistening instead of all yellowish and hard looking like bone. And we're going to pretend like this is just a localized area, which is the type that you would treat with microfracture. You'd never treat an area this large and extensive with microfracture. This poor guy or gal needs a knee replacement, or at least a partial knee replacement. But if this were smaller, a smaller area like what I'm pointing out right here, and it was localized, in other words, it wasn't present all over the knee, then that would be a real good candidate for a microfracture. And so we're looking at the femur right here. Right down below there is the tibia surface. These are the two surfaces that rub against each other when a person walks. You can see on the screen what that looks like as I bend and extend this knee. So we're looking on the screen right now, and we'll take a little video of it. You'll see there's a lot of different ways of doing this with a mechanical punch, or this happens to be a nifty new device that actually drills just a set depth of 2 millimeters or so into the bone. So we can apply that to the bone surface like this, activate it, and we're just going to go ahead and drill our first little microfracture hole you can see right there. Our next little microfracture hole, we want to be tangent to the surface. And so you can see we would fill this area up with small holes that would stimulate new growth of fibrocartilage, of scar type of cartilage from the bone marrow up onto the surface, filling our defect that we have. So now you saw all the different techniques that we have. We've got the microfracture, Oates technique, the allograft, osteochondral allograft. There's one more technique, that's ACI, that you may or may not have heard of, where we take a specimen of a patient's own cartilage, send it to a laboratory in Boston. Those cells are multiplied in cell culture so that we get 40 times the number of cells back. Then we transplant that back into the defect as a separate procedure spaced apart by several weeks. So that is another option for larger defects that is commonly referred to as the ACI, or the autologous chondrocyte implantation procedure. Again, a 2-stage procedure. So you should talk to your doctor about which of these options, if any, are best for you, because they certainly don't all apply to all different patients, depending upon the location of the knee, your age, your activity level, and what your goals are for your knee function. Thanks.